Hello, everybody. Good afternoon, and welcome to a brand new series which we are doing called Expert Insights. I'm very excited for this new series because it's going to be like a reverse panel, and we'll have very eminent senior teachers who will be in the hot seat, so to speak, and they'll be asked questions by different people from all over the country regarding practical issues which they face, clinical cases which they've encountered, and diagnostic and treatment dilemmas which sometimes are not addressed in standard operating protocols and practice guidelines. Today, the first expert that we have is Dr. P.K. Shah, sir, who is well known to all of us. Dr. P.K. Shah is a past president of FOXI, Mumbai Society, IAG, IFUMB, you name it, the organization of OBGYNs in India, sir, has been a president. And he's actually somebody who has decades of teaching experience, both at KN and at Sion hospitals in Mumbai. Besides that, he's traveled extensively all over the country to probably every single society and every single nook and cranny of this country, which people like you and I can never even hope to cover in the past 3 or 4 decades. He is much beloved wherever he travels, and people attend in large numbers just to listen to him. Even today, more than 10 years after he served as president of so many societies. Today, sir is going to give us some expert clinical insights on a topic which many of us take for granted in clinical practice, and that's the issue of anemia. Now, anemia is something which is widespread in Indian women. We've been hearing stories from various different international organizations, including WHO and FIGO, as to how more than 50% of pregnant women in India, even today in the 21st century, are actually anemic. And this is a matter of great concern because anemia affects not only the mother but also the fetus. And to address the different clinical dilemmas that our audience has experienced, we invited them to give us their questions. Now we're experimenting with a brand new format in this particular series, which we call Expert Insights. Rather than people writing in questions, we thought it would be wonderful to have people sending questions in the form of a short video. We experimented with this by providing a Google link where people could shoot their videos and upload it into a Google Drive, and we've had some exciting results. Let's go through the questions which we have received, and I would request the backend team to play the very first video question and let's take it from there. I'm so excited. I hope all of you in the audience as well are looking forward to this exciting session.
Narhari, you are mute.
This first video is from Dr. Nagari Agasti, a much senior and beloved practitioner from Bhubaneswar. And sir, video has come in. I think owing to some technical issues, we're not able to hear the audio here in this studio, but I'm sure the audience can listen. Subbu and the Science Integra team will just work it out and we will have the video for it. So while they're working on the backend,
myself, Professor Dr. Maria Agasti, ONG from Bhubaneswar. As you all know, the iron deficiency anemia is a very common prevalent condition in our society, and also it affects much in pregnancy. So my question is, how should you evaluate the hemoglobin and how many times in a 9-month pregnancy, and how to address this anemia and what form of treatment for this iron deficiency anemia in the form of either oral therapy or injectable, that means parenteral, it may be intramuscular or it may be intravenous preparation. So that is my question. Thank you.
Okay.
thank
Narhari,
you, Dr. Agasti. Sir, I think he's asking a very basic and simple question. Basically, this is trying to ask whether the guidelines which are used internationally, the cutoffs which are used internationally, are they the same which we observe in India? Are they different? And what are the cutoffs for oral therapy, parenteral ion therapy, and blood transfusion? I think these are very basic questions which
Yeah,
all of us
very
need
true.
to understand.
Very
Please
true.
go ahead, sir.
So, first of all, your one of the questions was that how many times do you do hemoglobin during 9 months? So the World Health Organization has come to our rescue and they have said that you can do first hemoglobin estimation in first trimester and second time hemoglobin estimation anywhere between 24 to 28 weeks. But don't restrict yourself to only these two because most of our patients come late for registration. So I think that is the first time you will do hemoglobin when she comes to you for registration. That is number one. And then again at 24 to 28 weeks. But do not restrict to only twice. If you feel clinically the patient looks anemic, you can do anytime. There are no restrictions at all. Okay. So that is first thing. Number two, you ask that whether you should give oral iron or intramuscular iron or intravenous iron. Now, one thing I want to tell you is that intramuscular iron is given up. There was a time when we were using iron dextran injection. We used to give it even total dose in those days. The patient used to get severe reaction in the form of arthritis of the knee joint and they wouldn't be able to walk. But we had no option at that point of time and we were giving them intramuscular injection of iron dextran and even Jectofer. It is given up now because we have safe iron preparations available. We have iron sucrose, we have ferric carboxymaltose, and a very new molecule which is supposed to be the best now, that is iron isomaltoside, injection I3. Okay, so these three things. Now, how are you going to decide whether you will give intravenous iron, you will give blood, or you will give oral iron? It's very simple. If it is a mild, now first of all, I want to take you back to the basics that what is any iron deficiency anemia. In India, we believe that if the hemoglobin of a patient is 10 grams or more, she is not anemic. That is totally wrong. The international standard is 11 grams minimum. So if a woman has hemoglobin 11 grams or more, that is normal. If her hemoglobin is between 10 grams percent and 10.9 grams percent, she is mild anemic. It's mild anemia. If she is 7 grams to 9.9 grams percent, she is moderately anemic and she is hemoglobin is less than 7 grams per deciliter. She is severely anemic. Please remember this very clearly and follow it religiously. This 10 grams, I still don't know because since the time I became houseman in 77, we take this 10 grams to make the patient fit from anesthesia point of view. So I think the whole thing has to change now, irrespective of what you believe in. 11 grams is a normal hemoglobin, anything more than 11. Now,
Thank
if the patient has mild anemia, whether during pregnancy or otherwise, you can start with oral iron. Now, again, here the WHO and the Ministry of Health, Family Welfare, Government of India have given different options. But because we are in India, we will follow the government's instruction as far as oral iron is concerned during pregnancy. So give 100 milligram of oral iron plus 5 milligram of folic acid for 180 days. That means in 2 trimesters, second and third trimester, and continue it for 6 more months after delivery. So the things have changed now. Okay, this is last 1.5 years that things have changed. Instead of 3 months post delivery, now it is 6 months post delivery, so that the iron stores don't remain depleted. That is one thing. 100 milligram of iron, 5 milligram of folic acid, 180 days during pregnancy, after first trimester and 180 days after delivery. I hope it is clear. Okay.
Yes, sir. Thank you very much. I think
If
that
a
is the source of that Baraka Nara which we've been hearing so much about.
now, intramuscular iron, I told you it's given up. Please, today we have progressed so much that we have very safe molecules available for practice. Do not use intramuscular iron. That is one message I want to give you in the afternoon today. Now you have option of intravenous. If the hemoglobin is less than 10, if she is mild or moderate, moderate to severe anemia, you can give her intravenous iron. Okay, straightway intravenous iron if the hemoglobin is less than 10. But suppose you are given oral iron for 1 month. You repeat the hemoglobin. If the hemoglobin has not risen by 1 gram per deciliter in after 1 month of oral iron, again she is a candidate for intravenous iron straightway, even if it is mild anemia. Please remember this. Okay. So that means she is not responding to oral iron. Now, intravenous iron, you have iron sucrose, you have ferric carboxymaltose, FCM, and now you have injection I3. There are 3 I's in this particular molecule, intravenous iron isomaltoside. So that is why it is called injection I3.
Thank you, sir. So we'll come to that in one of the later
Okay.
questions. Can we
Okay.
go to the next question, please? Back and
Please,
please. I
please.
think we have one more question about oral iron, which is very interesting. Can we have that?
Aditi, go ahead.
Hi, I'm Dr. Aditi Tandon, and my question is deworming essential before starting oral iron therapy?
Yeah. I think as a part of strategy for managing iron deficiency anemia, especially during pregnancy and even otherwise in women especially, the government has very clearly said that you must do deworming of all those patients who have iron deficiency anemia, irrespective of how serious it is, mild, moderate, or severe. How do you do deworming? Very simple. You can give albendazole 400 milligram stat, and that is a government's policy. But you can give even tablet mebendazole 500 milligram stat or 200 milligram 3 days. Okay, so that comes to totally 600 milligram. I hope it is clear.
Yes, sir. I think this is part of the
Absolutely clear.
operational guidelines,
Yeah,
and this is administered at the primary health center, even by the ASHA workers who go out into the outreach.
absolutely, absolutely.
That's something which is very important, especially in the interior, maybe not so much in our metro city. We have one more question. I think it's from a very familiar face. Back and forth. Can you hear a question, please? I think I know this question.
I think this is Pratik Tambe
Hello,
himself.
sir. This is Dr. Pratik Tambe from Mumbai. When we were medical students, we were told to prescribe something called as double oral iron and triple oral iron. I've always wondered whether there's any scientific rationale to giving this so-called double oral iron or triple oral iron, whether it actually makes sense, or should we straight away prescribe the patient and offer her the choice of taking parenteral iron, since we now have much more safer and more effective formulations available? What do you think, and what does the science and the evidence say?
Very
Thank you for
good,
taking
very
my
good.
questions.
I think this question hardly anybody asked. That is first thing, Pratik. A good question, because you feel that there are so many preparations available today in the market as far as oral iron is concerned. And when you have those MRs coming to you from different companies, they feel that they make you believe that their product is the best. Now, please remember one thing. There is no point combining different types of iron. That is one thing. You can give whichever iron you feel you are comfortable with, or you have been prescribing and your patients are quite comfortable with. You can continue that. There is no need of double oral iron and triple oral iron and all those things. Why? Because the upper limit of oral iron is 160 milligram per day. So you can't go beyond that. Otherwise, the patient is bound to have side effects.
Actually, 10% gets absorbed.
Yeah, and only 1 to 8%. This is
Exactly.
the government's information that only 1 to 8% gets absorbed. That doesn't mean you keep giving more and more iron to the woman because she's not going to tolerate it. Even we can't tolerate such high doses of iron. So please give only whatever iron preparation you feel is good in your practice and your patients have approved oral iron. So you continue with that. Don't keep changing oral iron just because you heard of something from somebody. Okay, that is one simple thing I feel you should do. But do not cross 160 milligram per day. Try and avoid going beyond 100 milligram. That is a safer thing, which has been told to us by the Ministry of Health and Family Welfare, Government of India.
Thank you, sir. I think you hit it on the head when you just said a couple of minutes ago that
Ah,
you need to relook at the hemoglobin 4 weeks after starting ONF. If there is no increase of 1 gram per deciliter
yes,
or greater in the HB level, then it's
yes,
time to rethink your strategy. If we followed this simple clinical practice point, the necessity for blood transfusion and last minute halla gulla, refer to tertiary care center, all of those would be cut down by a very significant amount. I think that's a very good practice point that you brought out.
very true. So I think the second message, what I told you, intramuscular iron, not to be used in practice today. Number two, when you give oral iron to any patient coming from high society or poor patient, if her hemoglobin does not rise by more than 1 gram per deciliter in 1 month's time, straightway switch over to IV. Simple, very simple. So this is the second message that you should keep in mind.
For
Now,
IV iron, there are so many preparations. Which do
yeah,
you think would be the preferred preparation in today's world?
okay. Now I think he has asked me a question whereby people are going to really pull my legs. But after going through some of the latest preparations which are available today, I feel that injection ferric carboxymaltose and injection I3, that is iron isomaltoside, both are equally safe. Only thing is that iron sucrose, which came first in the B category medicine,
Second
iron
generation.
sucrose, FCM, and I3, all three are category B for pregnancy, and you can use any one of these. But because there was nothing else available when we were using all iron dextran and all those things earlier on, we started using iron sucrose. Unfortunately, there were many cases of anaphylactic reactions. Please remember this. I have seen deaths in KEM hospital and even a Sion hospital, though not in my unit. But that doesn't mean anything. Who was responsible for these deaths is a different issue altogether. But you can have severe anaphylactic reaction, and if you are not next to the patient, you do not have the kit ready for management of anaphylaxis, you may lose the patient. So that is what happened to iron sucrose. Secondly, you can't give more than 600 milligram of iron sucrose in a week's time. And you can't give more than 1000 milligram of iron sucrose or FCM during pregnancy. Now they have said that you can give up to 1500 milligram of FCM during pregnancy, not at a time. At a time, 1000 maximum for FCM and 600 milligram per week for iron sucrose. Whereas injection I3, the iron isomaltoside, you can give in one shot 1500 milligram. Now remember what has happened when we were students, we were residents many years back. We were told that the formula for giving total dose iron is 2.4 multiplied by weight of the patient in kg multiplied by deficit of hemoglobin. Now, mind you, you have to take normal hemoglobin as minimum 11 and not 10. So, if suppose she is 8 grams or say take 9 grams and you want to bring it to 11, that means deficit of 2, 50 kg, she is suppose on an average. So, 100, 50 by 2 multiplied by 2 is 100 plus 2.4. So, how much it comes to 240 milligram, okay? Plus, what has changed in a big way is replenishment of iron stores. We were told in those days 500 milligram for replenishment of depleted iron stores. Now it is 1000 milligram. Now that has changed the whole formula in a very big way. So if a patient has 9 grams hemoglobin, she will require 1240 milligram of elemental iron total dose. You can't give in one shot if you have FCM. You will have to call her almost 6 times, 7 times if you want to give iron sucrose. Whereas you can give injection iron isomaltoside in one shot, you can give up to 1500 milligram. Now that is one of the biggest advantages. Let me tell you, no patient wants to go to doctor just to take injection. As such, they are worried about injections. So I think this is a very big advantage that I have seen in this particular new generation iron intravenous preparation which is available. Pratik.
So compared to the sucrose and the iron dextran horror stories which all of us have relived in the 80s and 90s, and we've actually seen them as students and as residents. All those are now gradually being phased out. We have better preparations that are available with the convenience of less frequent dosing, and
Yeah,
the newest generation now allows you proper, this is the genuine real total dose iron in one single sitting. That's the convenience that it
absolutely.
offers. I think that's a very good and important key practice point there. Can we go to the next question, please, Pratik?
Dear friends, I am Dr.
Wait, before
Priyankur
you
Roy.
say anything, Priyankur,
I am an
many
associate
happy
professor
returns of
at
the
Dr.
day.
Shah Medical College in Saharsa.
I don't know whether you
We
can hear
all
me.
know that anemia is quite very prevalent in the Indian scenario because, of course, of the fact of multiple pregnancies, not frequent, not gaps, adequate gaps in between the pregnancies, probably malnutrition, undernourishment, and also in some cases low socioeconomic status. So it's very, very important for us to know a couple of things which will be probably very, very important for clearing the doubts of many of us, including many of our patients as well. So I'd like to have a couple of questions that I would like to ask over here. Number one, of course, is the importance of ferritin levels in the evaluation of anemia is something that we definitely would like to clear our doubts regarding. And secondly, when should we explore the need for blood transfusion in anemic patients? Thank you so much, and I hope the answers will clear my doubt as well as many others. Thank you.
Priyankur, I know it is one-way traffic that you can't hear me, but if you are hearing me now, I want to wish you many happy returns of the day. That is first thing. Number two, a very valid question that when you have a patient coming to you, what should be the ferritin level, whether it should be done or not. Now, this is a third message I want to give to all the obstetricians and gynecologists listening that any patient of iron deficiency anemia, please do ferritin. I am telling you, this is very, very, very important. Please do ferritin. That is one thing. Because when you have ferritin less than 30 microgram per liter, okay, that is 30 nanogram per milliliter, same thing. You know you are looking at a case of iron deficiency anemia. Now, why am I saying this is that when you think in terms of other anemias, like thalassemia, suppose you take for granted. In thalassemia, the ferritin level will be either normal or even raised. Whereas in iron deficiency anemia, you will have hemoglobin less than 11, serum iron will be less than 60, the iron binding capacity, total iron binding capacity has gone up, and ferritin is very low, less than 30. Now, when you have this combination, you know you're looking at iron deficiency anemia. In addition, you have done the peripheral smear, which will give you a clear-cut idea that you are looking at a microcytic RBCs. PEG cell volume is less than 80. Now, all these things in combination will confirm that this is iron deficiency anemia. Now, if the ferritin is normal, even serum iron is normal or even elevated, and you have iron deficiency anemia, please think in terms of thalassemia. You will have to do electrophoresis of hemoglobin and then confirm. But ferritin is very, 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 very important. And henceforth, whenever you order investigations in suspected cases of iron deficiency anemia, please add ferritin. Okay, right.
So I think sir has
Now,
again underscored the importance of looking at the entire CBC, the RBC indices, not only relying on hemoglobin
yeah,
alone and
correct.
blanket assuming that all anemia is equal to iron deficiency anemia. There are certain patients who are not iron deficiency anemia. They may have megaloblastic, they may have sickle cell, they may have FAL. And if you assume that everybody is iron deficiency anemia until proven otherwise, you are one day going to fall into a trap and you are going to miss the diagnosis. So please beware, look at the entire CBC, look at the peripheral smear, and order the entire gamut of inventory.
Now then,
Relying only on HB alone is outdated in today's world.
absolutely. Complete hemogram, especially hemoglobin, MCV, serum iron, total iron binding capacity, and even you can do transferring levels. Of course, people don't ask for it, but at least these things and peripheral smear, this has to confirm. Priyankur asked very important question as to when to give blood during pregnancy. Now, I will not go into very detail, but the WHO has divided into three parts: during pregnancy, during labor, and during postpartum period. Suppose period of gestation is less than 34 weeks. Okay. The hemoglobin is less than 5 grams per deciliter with or without congestive heart disease, congestive heart failure. Please give blood straight away. That is one thing. Number two, if the period of gestation is more than 34 weeks and the hemoglobin is less than 7 grams per deciliter, that is an indication for blood transfusion. During antenatal period, if she has acute bleeding, acute hemorrhage, again, depending on the hemoglobin level, that is one more indication during pregnancy of blood transfusion. Blood transfusion, when I say, I mean the products. Okay, right. Intrapartum, during delivery, if the hemoglobin is less than 7 grams per deciliter, again is an indication for blood transfusion. In postpartum period, if patient has anemia with signs of shock, acute hemorrhage, hemodynamic instability, and the hemoglobin is less than 7 grams per deciliter, please give blood straight away. Now, I want to say something which will definitely give you help. It's not that just because Pratik and myself, we are sitting in Mumbai, blood is available. It's not an issue here in Mumbai and metro cities. But if you are in a very small place, city, blood is not available easily, you have to get it from a long distance. Let me tell you, one way there is a very good replacement of blood for the time being is again injection iron isomaltoside. I am not saying this has been published, that it is an alternative to blood transfusion. Till the time the blood is arranged, you can give her iron isomaltoside by the time the blood comes, if it is going to take a long time. Now, this has been published. So please keep it in mind. In case you need blood, not available for maybe 6 hours, 4 hours, whatever it is, please try injection iron I3, iron isomaltosate. Okay, Pratik.
Thank you, sir. I think that was a very good clinical practice point again. We often used to see horror stories where patients were referred at 36 weeks or in labor with hemoglobin of 4 gram and 5
Yeah,
gram.
yeah,
Those
yeah.
days are thankfully in the past. We rarely see patients like this, but I'm sure somewhere in the interior at some district level hospital or a primary health center that is still happening. In those kind of clinical situations, maybe blood transfusion will help, and if blood transfusion is not available, then in an emergency measure, you can always give parenteral iron in a total dose form in a single shot in one sitting at the end of the day. Second team, can we go to the next question, please?
Hi, Kunal.
Hello, dear friends. I'm Dr. Kunal Doshi, Joint Secretary Foxy, practicing in Mumbai at Ashish Women Care and Fertility Clinic. Anemia is still very prevalent in India, and as we all know, we have many treatment options available in our armamentarium to treat this common problem. I have two questions. The first one is, what should be the guidance of treatment based on hemoglobin level? And the second question is, what should be the time interval between two doses of parenteral iron? Hope the answer to this question will solve my query and the others watching this webinar. Thank you very much.
I think the first question we already answered and we have covered, I
Yes.
think.
Yes.
So do you want me to again go into the details?
If you could just summarize that in one or two sentences for emphasis.
Okay. So if the hemoglobin is between 10 and 10.9, that means less than 11. 11 is the normal hemoglobin. Please keep it in mind. So if it is between 10 and 10.9, it is mild anemia. You can treat it with oral iron. Give it for 4 weeks. Repeat hemoglobin. If the hemoglobin has not risen by 1 gram per deciliter in 4 weeks' time, straightway go to intravenous iron. If the hemoglobin is less than 10, but more than 7, that means 7 to 9.9, it is a moderate anemia, and less than 7 is severe anemia. So this moderate anemia, straightway treat with intravenous iron. Please remember this. And we just now talked about it, that if the hemoglobin is less than 7, during pregnancy, during labor, or postpartum, you can give blood products, okay? But in case the blood products are not available, for whatever reasons, you are coming from a very remote place and all that, you can still give injection I3, iron, intravenous iron isomaltosate. Now that is the first question which I have answered. The second question, how much time between two injections? That is what you asked. So again, I want to repeat for iron sucrose. In 1 week's time, give maximum 3 doses. There should be at least 1 day in between 2 doses, 24 hours in between 2 doses. Please remember this. Okay? You have 2 days, no issue. So that is one thing. Ferric carboxymaltose, if the requirement is more than 1000 milligram and you have divided into 2 equal doses, you give the first half of the dose of FCM to the patient and call her after 7 days. That is earliest. It's not that if you're not called her after 7 days, you can't give it. You can give any time after 7 days. That is simple thing. Same thing is true for injection I3, that is iron isomaltosate. But I told you, most of the patients of anemia, like say, take it 7 grams, and you want to bring it to 11. That means deficit of 4 grams is there. Multiply by, if her weight is 50 kg, it comes to 200. Okay, 50 multiplied by 4 is 200. Multiply by 2.4 is 480 milligram. Plus 1000 milligram for replenishment of depleted iron stores. That comes to total iron that that patient requires with hemoglobin 7 is 1480 milligram.
Which can be given in one sitting.
So you can give it in one shot. because
Absolutely.
I3 injection, you can give maximum up to 1500 milligram in one sitting. You don't have to call her again second time. I hope it is clear.
Yes, sir.
So
Perfect.
FCM between two doses at least 7 days. I hope I have
Thank you.
answered Kunal's
Yes, sir.
questions.
Perfect.
I wish it had been live questions because it's a nice thing to talk to people who ask questions.
I'm
Yeah,
sure there will be
I
questions
think
and
next
follow-up
time.
in the chat box as well. We'll take those at the end of the event. So I
Okay,
wanted to ask you a very practical question. Now, we mentioned a little while back that when we give oral iron, the increase in hemoglobin at the end of 4 weeks of good compliant therapy should be at least 1 gram per deciliter. What is the increase that you anticipate if we give parenteral iron? And how much more is the increase in HP as compared to oral?
very good. So now you take for example iron sucrose or injection FCM. You should have an increase of 2.5 grams per deciliter after about a month's time.
Okay.
Whereas injection I3, the manufacturers claim that it increases the hemoglobin by 2.85 grams after 4 weeks. So slightly more increase in hemoglobin also is there with injection I3 compared to either iron sucrose after giving full dose and injection FC.
That's a very good recommendation, sir. So if you get a woman even with hemoglobin of 7 or 7.5 grams at 36 weeks, by the time she goes into labor, her
Yeah,
hemoglobin will have come up to at least 10, 10.5. It may not
sure.
reach 11, which is ideal,
Yeah,
but
yeah, yeah.
at least 10, 10.5 would be something which we could expect. And that's a very important message that we need to give to the audience that with parental iron therapy, many of us are reluctant to administer IVIF because we are afraid of anaphylaxis,
Yeah, yeah.
of reactions, and many of us may not have the facilities to have an emergency tray or a nurse supervising, etc. But with these new formulations and molecules, anaphylaxis is very rare. Plus, you can give it in a short time of just maybe 15 or 20 minutes, and patient
True.
can go home. There's no admission
Yeah.
also required, very honestly.
No, they are just to be kept under observation when you're giving IV.
Correct.
Maybe you can maximum after finishing the dose, you can keep her for about half an hour, 1 hour. But remember one thing, any intravenous iron preparation you want to give of any company, reputed or otherwise, please keep a kit ready for anaphylactic reaction. That should have evil corticosteroid at least and some IV fluids. Okay. I'm sure everybody has oxygen at least. And you should immediately give a call to a medical consultant who can come and see this patient if at all required. But if you are giving blood, I told you earlier on, less than 34 weeks, more than 34 weeks, 5 grams and all, please see to it that you give her therapeutic dose of Lasix. If she is on the verge of getting congestive cardiac failure, don't give 20 milligram, 40 milligram. You can give up to almost 100 milligram, up to 100 milligram, and then give blood. Otherwise, she will go into failure when she was not in, and you have not given injection Lasix. So Lasix is also equally important to prevent these patients with severe anemia going into congestive cardiac failure.
I think that's a
Yes.
very important observation coming from a
Yeah.
teaching institution with so many decades in experience. So thank you very much for that important take-home message. Can we go to the next question, faculty? I think we have two more left.
Hi
Shamal.
everyone. This is Dr. Shamol Sheth from Kolkata, currently the Vice President of the Bengal Obstetric and Gynecological Society and the Vice President elect of FOXY for the year 2025. Now, to talk anything on anemia, we know that anemia is prevailing in our country for last several years. To be very honest, it's for last few decades. And since our student days, we are aware that yes, anemia is a big problem, especially amongst the women of our country during any period of their age, starting from the adolescence up to the childbearing age, and then even after the perimenopausal age group. Now, there are so many initiatives are taken from the pharmaceutical industry and from our part as obstetrician or gynecologist. But there are several initiatives from our sides, our organizations as well, anemia-free programs, anemia eradication programs, like all those. But anemia is still prevailing almost in the same magnitude. All the different kinds of iron preparations, iron formulations with different compositions, even intravenous formulations are there in the market within the affordable price range with some products, but still anemia prevailing very much. And not only anemia itself, and this anemia can bring about several other associated problems, medical problems or other health problems to our women. Now, as a gynecologist, as an obstetrician, we are always concerned for the women of our society. Now, I have got two pertinent questions on this anemia. One is, can India be ever made anemia free? At least Indian women can ever be made. If not, what should be the ideal steps or what initiatives should be taken from everybody's side to make our women anemia free? Thank you very much.
Okay, Shamal, that was a long question, I thought, but you made it very easy for me. Whether we can make, I hope you can hear me. Pratik, you
Yes,
can
sir,
hear
we
me?
can hear you.
Okay.
Loud and clear.
Whether you can make all women of our country anemia free. Now, let me tell you, Ministry of Health and Family Welfare, Government of India in 2018 took up this issue very seriously, and they've given a slogan, Anemia Mukt Bharat, AMB, Anemia Mukt Bharat. I'm not a pessimistic person, but I know it is not going to happen. That is first thing. You can never ever have our country without anemia in women or even men. It's something very simple. Ours is a very vast country, huge country, 14 billion people. We can't reach them in each and every part of our country. Government earlier on 60s and all started with fortified atta. Pratik, I don't know whether you remember that. Fortified atta. They had iron inside the atta. Okay, that was one thing. Then they said that any iron deficiency anemia of any level, do deworming. So that was again a very good suggestion. Then they said that you should have proper diet which is rich in iron, and the whole details were given regarding it, that what you should eat, what you should not eat and all. But in India, let me tell you, we have a very bad habit of having tea every now and then, and coffee also, Pratik. Now all these things, tea, coffee, milk, soya products, all these things, they reduce iron absorption. First of all, whatever is the total iron required, we do not have it in adequately in our food, especially during pregnancy. And that's the reason that we have to give oral iron or supplementary iron to women who are pregnant, because their diet does not contain adequate amount of iron. We have very wrong dietary habits in our country. You give them in writing jaggery and all those things which have rich iron, meat, fish. Now, which poor person is going to eat meat and fish and liver and things like that? It's not possible. So green leafy vegetables, jaggery and all those things they can eat. So that was again one more movement that occurred, that we should improve the diet and the dietary habits so that she takes iron content which is better in those dietary items. Now absorption. is again, I told you, you must avoid certain things, as I told you just now. Use vitamin C, something very simple. Limbu, okay? All the orange juice. Okay, poor people cannot afford to have orange juice, but at least lime is available. So that increases the absorption. So we have to look at all these smaller things, and not only us, the doctors. I'm not even only obstetrician and gynecologist. IMA also should take up this issue very seriously with the Ministry of Health and Family Welfare and see to it that they talk to their any patient, not gynec patient, any patient coming to them, the family doctors, the family physicians, they should improve their knowledge about iron in diet and the supplementation. But whatever you do, whatever WHO says, whatever Ministry of Health says about how much iron for how many days during pregnancy, how many days after delivery, it's not happening. Even if you are a doctor, lady doctor, and if you have to do it, think whether are you going to do it. We are good at not following things. So anemia mukt Bharat is never going to happen. I'm sorry to say this. We must all of us try and see to it that the incidence of anemia, which is 52% in pregnant patients, is brought down just like maternal mortality. We have come below 100 per 1 lakh births. So we should try and see that that level is brought down over a period of time, 5 years, 10 years. Let us have from 50% to 40% to 30%, like that. And that is achievable. So anemia mukt Bharat is not possible in our country.
But at least we can aim
Yeah, yeah.
towards that.
Yeah. It's a sad thing. I'm very
Practical.
unhappy about the whole situation that for last so many years now I'm in OBGYN since 1977. 41 years we have been hearing about this anemia during pregnancy, 50% and all. In Shah Hospital, KM Hospital, we saw almost 2/3 patients coming having anemia. Such a sad thing in Mumbai. Think of it. And we have to all sit together and really decide what should be done to really achieve something better. Yeah,
Thank you,
Pratik.
sir. I think you highlighted the importance of diet and nutrition in a big way. As Hippocrates used to say 2000 years ago, let food be thy medicine and not medicine be your food. Thank you
Nice
so
word.
much for highlighting and stressing on that. Can we
It's
go to
very
the last
irritating.
question?
See, government has said 180 days during pregnancy, 180 days after delivery. That means 360. Means 1 full year you are going to take iron. I doubt. I doubt. Once she has
Compliance
delivered,
is going to be an issue.
she's gone. Unless
Lots
the
to
baby
further.
has some problem, she will not come back to you. How many of us ever do hemoglobin of a patient who is delivered with us? Hardly. The very important issue which we have not discussed, Pratik,
Yes, sir.
is number one, cost. The cost of injection I3, that is isomaltoside, is almost half of that of injection FCM from a reputed company. Please let me make it very clear. We have very good reputed companies, no question about their products. But the injection I3 is almost half compared to them. Okay?
And postpartum iron administration is something which we should all practice.
Yeah, no. I'm coming to that. There is a very good paper published, sorry, which says that if you give one shot of 1000 milligram of injection I3 immediately after delivery, if her hemoglobin is less than 10, and send her home, her chances of getting fatigued once she goes home and starts working are reduced like anything. In our practice, when a woman who is delivered with us comes back to us, how many times we asked her whether do you get fatigue?
I think it's taken for
Patient tells
granted.
whatever problem she has, and we manage that. But we never ask that patient whether you get fatigued when you go back home. with a borderline hemoglobin. So please give what I used to do at KM hospital before retirement is 24 hours after delivery, irrespective of route of delivery, we used to do hemoglobin. If the hemoglobin was less than 10, we used to give 1000 milligram of intravenous iron, either FCM, of course, that time it was FCM, but now you can give injection I3. 1000 milligram, one shot, send her home next day. And this will do tremendous good to this woman who goes back home and starts working. I'm not talking about high-fi women who don't do anything even after delivery, and they have enough number of servants and cooks and all those people. Obviously not. I'm talking about a middle class, low middle class family, where a woman has no option but to work. I think this is one more thing I thought I should have at least told all the people who have joined us.
Yes, sir. I think
Ah,
that is another very
one
important clinical point. Yes, sir.
very important thing which I came across, that 79% of women who got oral iron treatment had lower than normal ferritin, levels at delivery compared to just 4.5% of women who had intravenous iron, were 79% and were 4.5%.
Huge gap.
So this is something I think people should know. When you want to talk to the patient, it's very easy for us. Arey bhai, ek injection le lo, ho gaya. So that woman who has come to you, she is not going to accept any injection. So if you tell her that the parameter will change drastically if you take one injection and it will be just one shot, and even I will be standing there or my doctor will be standing there when the injection is being given within 15-20 minutes. I think it makes a lot of difference. You must be a good counselor when it comes to anemia Mukt Bharat.
Thank you, sir. At the flag end of the program, the PH, the register, or the showstopper, so to speak, is one of your own students who has sent in a question. So we saved it for the last.
Wow.
It's a very familiar person for you.
Niranjan.
Hi, I'm Dr. Niranjan Chavan, professor and unit head at Shah Hospital, Mumbai. I firmly believe that learning is a lifelong process, and I'm very lucky and honored to be mentored by my guru, none other than Dr. P.K. Shah sir. Today, I get this opportunity to ask sir a question whether the new kid on the block, ferric maltol, is going to do any difference in the management of mild and moderate anemia. Furthermore, I want to ask you, sir, that the oral iron preparations in future, would they replace the IV iron preparations for the treatment of anemia? Thank you so much.
Thank you, Niranjan, for your kind words. And answer to your second question first. That in no way oral iron preparation, let it be anything. I know the details of many of them. Some of them are really good, but they will never ever replace intravenous iron. For a simple reason is that the oral iron, when you give, only 8 to 10% gets absorbed, and you have an upper limit of giving maximum oral iron per day, that is 160 milligrams. Patient is not going to tolerate that high doses. So there is no question of oral iron replacing intravenous iron. That is one thing. Intravenous iron, when you talk about, you have given full when it comes to injection I3, or even for that matter, pericarboxymaltose, you can give 2 injections. You know that you have delivered all the required amount of iron to that woman. When you give oral iron, you prescribe. How do you know whether the patient is taking it at home or not? She is very smart. She takes it and she realizes there are stools become black. So next time when she comes to you and you ask, कैसे हो, तुम्हारे dust का color कैसा है? Then she will say it is black, and you know that she is taking. But for all you know, she might not be taking it at all because of side effects and intolerance. And this happens very commonly in Indian women. I'm sorry to say this. So there is no question of oral iron replacing intravenous iron. That is first. Number two, you said about ferric carboxymaltose. It is not new. It is there for quite some time now. And it has totally replaced iron sucrose, if you ask me. Today, we want a safer drug, like even injection I3. We want a drug which does not have anaphylactic reaction, which does not cause mortality. Iron deficiency anemia causing mortality is one issue, and treatment of iron deficiency anemia causing mortality is a different issue altogether. It's a serious matter. That's the reason iron sucrose has gone out of favor. Still it is used. I'll tell you why. GPs, general physicians, they like iron sucrose. Why? Because in one visit, he will give 200 milligram. And patient will at least require about 1000. So patient will have to come 5 times. Every time he will charge her. And if you look at the total amount of money the patient will shell out for iron sucrose, would be more than either injection FCM or even injection I3. Secondly, the government of India, Ministry of Health and Family Welfare, has sent now free of cost iron sucrose to all the government hospitals, hopefully. Many of them have received it. Now, what is happening is that in our country, that when a new thing comes, government doesn't accept it immediately. By the time they accept that yes, it is a good thing to be used, already the next generation thing has come in practice. Now today we have third generation injection I3 available. Injection isomaltoside is available. And now iron sucrose is being pushed to all the government hospitals free of charge. So I don't know why such a thing is happening, why we are lagging behind, why there is a latent period in responding to the demand. And I feel it is Foxy that has to push things very hard with the government to see that the available latest treatment is made available to all these hospitals where you give free of cost. What is the point in giving something which nowadays we don't use? Injection iron sucrose we hardly use. I have talked to people about iron deficiency anemia at almost 25 places, and I asked them, and not many people use iron sucrose, but they say that now it is available in government hospitals, so we have to give it. Look at the whole situation. The same government wants it from 2018, Anemia Mukt Bharat, and they do not want to accept the latest that is available, which is safe, which is better as far as hemoglobin rise is concerned. No anaphylactic reaction so far, 40,000 cases that are reported. There are many more who have never reported. 40,000 cases of injection I3, not a single death, no anaphylactic reaction, half the cost, safer, better hemoglobin rise. What more do you want? I think government has crores of rupees. They are giving crores of rupees to various people in various fields. Fine, we can't complain about it. But when we really need their help, I think they should listen to us once in a while. I hope Mr. Nadda, who has come back as a Minister of Health and Family Welfare, we have a better relationship with him, and I hope things work out well in favor
Thank
of
you very
Indian
much,
women.
Dr. P.K. Shah, sir, for highlighting all the important challenges to implementation and at the same time highlighting that IV iron is not such a scary situation as we once used to be. The incidence of reactions and compliance is, of course, significantly improved from 2 decades ago. We
Yeah.
are now able and empowered to administer during pregnancy. It's a category B drug, and you can give absolute total dose iron in one single sitting without any issues in a matter of just 15 to 20 minutes. This is what will actually be a game changer as far as anemia in pregnancy is concerned, assuming it is iron deficiency anemia. Again and again, we need to reiterate that we need to rule out all other forms of anemia and then treat it as iron deficiency anemia. Thank you so much for sparing your valuable and precious time, sir, for giving us your clinical practice pearls. My gratitude to all the people who took the trouble of thinking of unique questions, recording them. Ask me, it is difficult to get videos from people because people are very scared of facing a camera. There are very few veterans like Dr. PK Shah who will come and extempore speak to you on camera live, but for 99% of the audience, it is not such an easy task. We've had 850 delegates who
Wow.
registered for this program. 700 plus have attended, and this, of course, will be available later on YouTube archive for anybody who missed the program and they can watch it. I'm very delighted to be doing this entire series of expert insights. Today was the first episode with Dr. PK Shah, a legendary teacher, and we hope to see you all very soon in the next episode. Looking forward to your unique questions, and together you and I will grill another expert on very important clinical insights in the very near future. Until next time, goodbye, God bless, and thank you for joining us.
Thank you and congratulations to you and Gleason. Superb.
Thank you, sir. Thank
Yeah.
you so much.